diabetes is foot.
Oh.
So that's it. After this, we're pretty much done. Then you pick up with thyroid for the most part. I mean, you don't love diabetes as much as I do.
Stacy hasn't been done much for it, so.
Okay, page 2. So we talked about the diabetes doesn't kill people, it's all the complications. So it's all the long term. Most complications don't show up for at least 10 to 15 plus years. So we know that if we, because of the DCCT trial, that if we intervene early, we can prevent or slow down the onset of complications. These are the things that not only can cause death, but also greatly impair people's quality of life. So there's lots of things we can do. So we're going to talk about the 4 or 5 major organs that are affected and the prevention and treatment of those once they occur. If you look on page 2, a lot of this is out of the DCCT. And this you should know. You should know this sheet. So we divide into microvascular and macrovascular complications. In preventing retinopathies, so prevention, it's optimized glycemic control and blood pressure control. Okay. For nephropathy, it's optimized glycemic control and blood pressure control. And then use an ACE inhibitor or ARB. For neuropathy and its sequelae, glycemic control, smoking cessation, and the use of routine foot exams will pick up problems early on. For retinopathy, the other thing you could add up there is routine retinopathy screening. Again, that won't prevent it, but it will pick it up early. Macrovascular, it's reducing macrovascular risk or cardiovascular risk factors. So blood pressure, cholesterol, triglycerides, aspirin, and smoking cessation. Now there you don't see glycemic control because glycemic control has not been tied to a big change in cardiovascular outcome. But it doesn't help. So, but the big emphasis goes on to those other decreasing cardiovascular risk. Those are important to know. So you see with microvascular disease, it's all about get the blood sugar controlled. Usually below 8% is the threshold. So these are the big standards of care. These are the things people will watch. If you're in especially in primary care, these are the things they will watch your group. They'll grade your group on these. Now that, I don't mean that's the only reason we do these, but these go a long way to preventing these complications in these folks. And that goes a lot towards the quality of life and quality of care. Retinopathy. So number 1 cause of new onset blindness in adults is diabetic retinopathy. There are 2 types of diabetic retinopathy. There's a more benign form and there's a proliferative form. So what happens in the eyeball, I think I've got pictures. Here you see the retinopathy. So in what happens in the eyes is it's the disease of the small blood vessels. So they get fragile and they leak. So you get these hemorrhage, you get cotton wool spots. You get lipids that leak out and deposit in the eye. You get exudates. You get macular edema. And so what happens is that these blue blood vessels eventually start to break down. So because that affects the oxygen carrying capacity to the eye, what the eye will do is it will make new blood vessels. Okay? And so when it does that, it makes a lot of them. And that's what proliferative retinopathy is. Let's see if I draw a picture. Yeah, I do. Okay. So when it makes a lot of those new blood vessels, it will usually crisscross them all over the retina. And those new blood vessels that it makes are usually not of a good quality like the ones you were born with. And so they will eventually obscure vision, or they will leak more, and they'll leak into vitreous humor, and you will start to lose sight. So when we get a proliferation of those little blood vessels, eventually you've got to have an ophthalmologist that will go in there and use a laser and obliterate them in order to save the person's vision. Okay? So, because one of the target organs of hypertension is also the eye, it's a double compound. That's why you see keep blood pressure normal, keep blood sugar normal. Those two things go a long way. The other is get the person in for an eye exam on a regular basis. It would be best if you would refer them to an ophthalmologist that specializes in diabetic retinopathy. Okay? But whatever you have available is better than nothing, but that would be the best. Dean McGee here in the city is one of the best in this area. They're very good. And they've got groups all over the state. Okay, so when to screen. If you go down for type 2, they are very easy. As soon as you see somebody that is new onset with type 2, you need to, that day you make a referral, same day you see them. And why would we do that? That's a progressive disease, but how long have they had the disease before you see them? Probably a long time. So they could already have the onset of changes in the eye, especially if they have hypertension as well, and by the time they are diagnosed. So that one is an immediate referral. Okay. Now with type 1s, they're normal until they're diagnosed. So the onset of changes in the eye is usually much slower. And for kids, before they hit puberty, there really seems to be a grace period. So what we do there is, it's for adults who've had the disease 5 years or longer, then we refer them, or children over the age of 10. But if they're 2 when they're diagnosed, we don't do them at 7. We wait until they're about 10 years old. Okay? See the difference there? Pregnancy is a whole different thing. Pregnancy tends to accelerate the onset of retinopathy. So we want to be sure they're screened before they become pregnant. And then we want to screen them during pregnancy, because a lot of times they will develop a retinopathy during that time. So screening them every trimester, and then postpartum. Okay. So pregnancy, so remember, pregnancy is a different deal. It accelerates retinopathy. We want to screen them before, see where they are, because if they already have trouble, let's say they were diagnosed when they were 2, now they're 32 and they want to have a baby. Well, they've had the disease 30 years. They could have significant retinopathy. So they would want to treat that before pregnancy, and then they would follow them during. Or they could see where there's changes, and they could follow those changes for acceleration during pregnancy. Okay? That's another reason why it's very good they plan their pregnancies. Okay. If their blood sugars are really in good control, and they have normal eyeballs, then the ophthalmologist may say, I don't need to see you for another 2 or even 3 years. That's usually the ophthalmologist's call. So if they come back and go, I don't want to see, they said I don't need to be seen for 2 or 3 years. Well, so you don't think, oh, you're lying because you don't want to go back, or that ophthalmologist is a dirtball. No, it could really be, if they're in good control, then that's great. That is a good sign. If they do find changes in the eye, macular edema, or they starting to have retinopathy, or signs of retinopathy, then they may start wanting to see them every 3 to 6 months. So that would be normal on that side as well. Okay. The treatment for retinopathy is laser. what are they called, what is the name? Yes. So what they'll go in and they'll do is they'll do hundreds of little focal laser burns all in their eye, and it usually will take several visits. They'll do that over. And that may go a long way in preserving their vision. Next page, one other thing I wanted to... So one thing you may hear is they can't take aspirin because that makes their retinopathy worse. Because there was an old study that pointed to problems with aspirin in advancing retinopathy. For patients who have cardiovascular disease that are on a low-dose aspirin, that is not a problem. They can continue to take the aspirin. So when to refer? Any level of macular edema, any proliferative diabetic retinopathy. It's one of the things that, as a diabetes educator, when I saw them for education, is I always empower the patient is that here's what you need, and you should, if your doctor doesn't bring it up, or your provider, you need to tell them, I'm about time, it's due for my eye exam. Dean McGee's really good because they will forward schedule, or they'll send them a note that says, it's time for your eye exam. They're good about keeping that in their database. But what your patients need to know is they need to keep records of it. So in our education classes, we would give them a chart, and we would tell them when everything was due, the different tests. So that was always one of my goals as an educator, is that you, as a diabetic, know exactly when you should be getting things. And if your physician or provider doesn't do it, you need to prompt them. I've never found a provider yet that took offense to that. So empowering them and telling them, you need this every year, or however often the ophthalmologist says. Okay? So that's eyes. Any question? Okay, let's move on to kidneys. Number one cause, or a very common cause of end-stage renal disease, dialysis, is diabetes. So we want to screen them for early disease. This is the one thing I see fall apart in primary care a lot. It just gets overlooked. Because it's fairly insidious, nobody looks for it. When I first got to family medicine, I asked them, it's like, why aren't you doing serum creatinines? Well, because we don't, why should we? Like, because a lot of our drugs are dosed off of it for renal function. So, we should be looking for signs and symptoms of renal disease all the time. If you've got an out-of-control diabetic that has hypertensive disease not well controlled, they are on the road to bad kidneys. Okay. So albumin is an indirect measure of what's going on in the glomerulus. Do you know the difference between a colander and a strainer? What's the difference? Size of the pores. Okay. So in the Bowman's capsule, you've got these, they call them fenestras. Fenestra means window, but it's these pores. So that's what all those little molecules can go through. But those fenestra are not big enough for proteins to go through, because proteins are big. Okay. But as diabetes affects those basement membrane of that glomerulus, those fenestra get bigger. So eventually they'll get big enough that albumin can go through them. So when we are checking the urine for albumin, if we find it, we know there's something going wrong in the Bowman's capsule, okay? So that's why we screen that. Normal excretion of albumin a day is what? 0 to what? 30 grams per gram for that. Okay. So above that is abnormal. Okay, so you do excrete a little bit of protein every day. There are some things that make it worse. So if you went and exercised really hard and then we checked your excretion, it might be elevated. If you have an infection, you have a urinary tract infection, it will go up. So stress will make it go up. Really out of control blood sugar will make it go up. So if you want to try to do these screens on days when that is not occurring. Okay. So usually we want 2 or 3, because they're very variable, we want 2 or 3 different tests in a 6-month period. We're looking for, if we've got 2 positives, then we would call them to have albuminuria. That's just an indication that the kidneys are being stressed and having problems from the diabetes. Usually their serum creatinine will go up, that'll start trending up first, then their GFR will start falling. Once you get on that road, there is no getting off of it. You can slow it down, but you can't prevent it from continuing to the end. Their renal function will continue to go down. So it's really important early on to stress good glycemic control, good blood pressure control. Okay, so next page. So who to screen? Your type 2s, right away. Adults and children, it's the same thing, 5 years after onset of disease. For the kids, it probably ought to be the 10 years again. I just left it off. Factors that increase the risk of progression to end-stage renal disease. Elevated blood pressure, albuminuria and proteinuria, poor glycemic control, smoking, high dietary intake of proteins, possible hyperlipidemia. Treatment, optimize glucose control, optimize blood pressure control. If they're already if they're non-dialysis dependent diabetic kidney disease, then lowering the protein may be of value. Next page, ACE or an ARB is not recommended. If they have normal blood pressure and their excretion of albumin is in normal range, don't put them on an ACE. There's no prevention. Yeah.
How come some of the professors say to put them on like Symmetrical for prevention of progression of kidney disease? Dr. Bonetta and Dr. McNeil both said that.
Okay, what am I saying that's different?
It's an ACE. Like Symmetrical is an ACE.
Right, I'm missing where I'm not right,
Well,
where
they
we're
said-
saying different.
Didn't it say don't put them on an ACE?
If they are diabetic and they do not have blood pressure, is not a problem,
Okay.
and they are no albumin, their albumin excretion is normal, there is no evidence to say you do anything to them at all if you put them on an ACE.
Okay.
Okay.
Because they were saying they're like, right when someone's diagnosed with diabetes, they automatically put them on like Symmetrical.
Well, you absolutely will see that done.
I'm just confused, so that's all.
Okay, so a couple of things, backing up. If you are doing it in order to prevent kidney disease, there's no evidence that that does that. If, when they're diagnosed, they also have high blood pressure, then put them on an ACE.
Okay, sweet.
If they're a person who doesn't have diabetes and doesn't have any kidney disease, you can still use ACE as hypertension. But if they are saying as soon as they're diagnosed, put them on an ACE, if they don't meet those other two criteria, you're not doing anything for them, except making them at risk for hypotension.
Yeah, sorry, I just got really confused.
Okay.
All of a sudden.
What they're speaking out of, honestly, is that by the time you see the majority of adults at this point, they've got one or the other.
Okay.
So for them, it's like, this is pretty normal. You know, it is rare that you will see a diabetic, a type 2. You'll see type 1s without hypertension and no albumin excretion. You'll see them. They'll tend to be more normal early on. But a type 2 that's middle age usually is going to have one or the other.
Okay.
So I think that's what they're
That
talking
makes a
out
lot
of.
more sense, because I was getting confused in my head there, but that makes so much sense.
The biggest thing to remember, if everything is normal, adding an ACE doesn't help them one whit.
Okay. Got
It
it.
doesn't change outcome. It doesn't keep them from moving on to kidney disease from their diabetes.
Thank you.
So I think they're just leaving out all that other information, and so they're telling you the end thing without telling you the reason why. But I think they would say the same thing.
Yeah.
I'm glad you bring it up, though. You should bring those things up. That's good. Okay, so once you put somebody on an ACE, and they've got, let's say their albumin is up, ACE or an ARB, and their albumin excretion is above normal. So should you continue to then monitor their albumin excretion? You'll have a lot of providers that'll go, no, I've got them on the ACE. It's probably a good idea to do it because then you can follow progression. I always did, because I wanted to see if we're progressing on. Because if they are, I was much more aggressive with their kidneys, because I wanted to keep them off of it. And it's a hard life to be on dialysis. So when their GFR starts falling below 60, now that's when they're stage 3. Really, pay attention to those folks. That's going to be a lot of your middle-aged type 2 diabetics are going to fall into that category. So be more aggressive with what you're telling them about their blood sugar, about their blood pressure control. Once they fall around, below 30, you can refer them to a kidney specialist. Now, probably all they're going to do is tune up their meds, but you've got them in a system, and you've got somebody watching them then, okay? And their goal is going to also be keep them off dialysis, but whenever you have to make that move, then you've already got them into a system. Make sense? For patients who don't have hyperalbumin, who don't have albumin in there or elevated, then any of the drugs that probably Dr. Britton mentioned that you can start with, the ACEs, the ARBs, the calcium channel blockers, the thiazide diuretics, all of those are appropriate. Okay. Most of this stuff you know. The only thing we're adding is what do you do now that they're diabetic? Okay? Only change. You're adding to what you already know. You already know to monitor their serum creatinine because it can go up, right? We talked about acute kidney injury from ACEs, and that's why. Why does their GFR fall? Serum creatinine goes up because their GFR goes down. Why is that? We've affected their efferent, right? The one. Afferent is the one coming away from the renal artery. That one is more under the control of prostaglandins. Comes in. Oh, okay, so afferent, efferent, ACEs and ARBs. Angiotensin 2 is the predominant one here, right? You vasodilate that, what happens here? Falls. So that's when their serum creatinine goes up. This is prostaglandins for the most part. Okay. So, and you're going to follow potassiums, right? So how often are we going to do this? Adults and children, again, 5 years after onset. Adults, type 2s, right after they're diagnosed. Another thing, I don't think I put this in here. I'll talk about it in pregnancy, but women who already have significant renal disease, who are young, who want to become pregnant, pregnancy will also worsen renal disease. Think steel magnolias. Somebody knew a diabetic when they wrote that. So it can cause the renal function to get worse. So we'll talk about that when we talk about the care of the pregnant patient, but I didn't put that down here. In fact, severe renal impairment is a contraindication of pregnancy in women with diabetes. Doesn't mean they still don't get pregnant, but we would advise them not to. Okay, questions about kidneys then? All right, let's look at nerves. Neuropathy. This is one of the more difficult, I think, of the complications to treat. We just don't have any good drugs. Once you start interfering with the ability of those nerves to work, you just can't regenerate. You can't get the myelin back, and the pain is difficult to control. So when we're doing neuropathies, we're usually looking more at the distal peripheral neuropathies. Here's Cameron with one of our dogs when he was about 14. Dr. Britton and my son tortured this dog. They loved him, but she was one of these dogs that she did not like to be touched in certain ways. And so what did they do? They would just pull her legs, because then she would snarl and snap at them, and they just thought that was hysterical. So she was a cattle dog. She was a tough old thing. She died this year. 15. She made 15. Let's see. Okay, so neuropathy. So any nerve in the body can be affected, autonomic, somatic, any of them. But the ones that people tend to know about and the ones that they tend to think about with diabetes are these peripheral neuropathies. So a lot of times they call them stocking glove because they affect the hands and the feet. And the feet more because you got that long axon that runs down from your spinal cord down to your toes, and that's the one that tends to get the most effect. So the screening for neuropathy is for the distal symmetrical polyneuropathy. Again, with adults and kids, it's 5 years after onset. With adults, the day you see them, if they're brand new or new to you, you should do a foot exam. And then for you, if you're in primary care, you should do it at least once a year. You will see on here that the recommendations are that they have a foot exam every time they're seen. More of that speaks to the endos, who are probably going to see them every 3 or 4 months, maybe 6 months, that they would do it. But for you, unless you're dealing with a person who has a high-risk foot, an annual, at least annual, would be sufficient. And that's what the standards say. So the diabetic neuropathy is the presence or symptoms and signs of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. So patients can have neuropathy for a number of different reasons. So they're saying rule those things out before. So clinical findings, so ways that people would describe them. You all have told me some of these before. They are very painful. Probably the most pain or the most discomfort I hear out of most diabetics is due to this kind of pain. Nerve pain is very lancinating. It's like having a knife stuck down your leg. Most of the patients I had described it as 1,000 bees stinging my foot. That's what a lot of them. But this would be common things: foot on fire or foot very cold, or people, sticking daggers into my foot. This one, I think, typified what a lot of the patients would tell me. So these are push pins all in that guy's feet, or bees stinging it. Or you all told me about that hyperesthesia, or aesthetics, not wanting anybody to touch, especially like sheets, and that's true. They can't stand anything to be touched. Numbness, tingling, prickling, all of those would be words that they would use. We're going to learn how to do this next week. Some of this I'll go over later. But we're going to look for sensory loss. That's one of the most important, and vibratory loss. Looking at sensation loss is important, because if we can identify where they're having trouble, then we can give them good education about what to do. It's almost like they need to let their feet, they have to think for their feet. Because pain is a powerful protection for us, and when you lose that, then your ability to protect your feet goes down. So the screening is, again, when you see a person, you would do that with type 2, do the foot exam the same day, and if they're type 1, it would, again, be 5 years after the onset. Look under the diabetic foot exam, just to kind of give you a preview of things we'll look at next week, is we'll do a derm. Here are some of the things you see. I have seen some. You should have Dr. Britton tell you some of his stories. He had a guy, did he tell you about the sheriff that he had out in West Oklahoma? So he came in and Dr. Britton wanted to look at his feet, and he goes, well, I can't get my boots off. I think his wife had died, and he was fairly rotund. He couldn't get his boots off. I don't think he had taken his boots off, if I remember right, like in 9 months. Yes, he couldn't get them off. So when Dr. Britton finally got him off, his toenails had grown up and over and around and into his foot. Yes, yes. Oh, I just can't tell you the things I have seen, and I usually have to beg people, and once you take off yours. So when someone enters a room, when I usually go get my patients, and I have them all say, there's a room, and I let them walk, and I watch them. I watch how they walk, I watch their gait. And I had one lady who was really limping, and I said, what is wrong? What's wrong with your feet? And she said, I have a psoriasis, and her psoriasis really affected the bottom of her feet. And I said, well, take your shoes off, and I want to see them. She goes, no, I don't want to do that. And so finally I'm like, I really need to see your feet. So what she would do is she would take scissors, and she would cut those psoriatic plaques off. Yes! she had little scissor cuts all over her foot. I'm like, oh my gosh! So I went and got a doctor because I'm like, okay, I gotta have somebody else look at this. So eventually we got her in with a derm, and we got the psoriasis calmed down. We got her foot, we got her in such beautiful shape. But if we had never had her take her shoe off, we never would have done that. So we got her all antibiotic up, and we got those feet cleaned up. And the psoriasis didn't totally go away, but we also got a promise, don't use scissors. I had to have her daughter take them away because that's the way she had done it. And she had lost so much sensation that she couldn't feel it. So to cut them off was good for her. So anyway, let's see. I don't mean to gross all out, but these are just typical. So we'll learn to look at vascular problems on a leg or a foot. One of the things we want to prevent is this. I have taken shoes off and found these. It's like, why haven't you told anybody? Sometimes they'll say, I did show it to the doctor, and nobody did anything. But they'll progress. They may show them a sore, but those sores will progress and ulcerate. So these kinds of ulcers are a problem because they get in the bone. And once they get in the bone and they cause osteomyelitis, then they often lose their foot at that point. Wound care specialists, to me, are the next to angels on earth because they can work miracles. Here's a Charcot Neuropathy. This is a complication of diabetic foot. You see, they call them a rocker bottom, and you can see why. Diabetes, they tend to lose the architecture of the foot. The tendons spread out, they soften, they lose that normal weight-bearing creation that the foot was made to do. And so parts of the foot start to bear weight that weren't intended to. And when they do that, they ulcerate. And when they ulcerate, then they won't heal. And if you don't have good nerve and you don't have good vasculature, then you start to ulcerate. And then you lose your foot. So this is what we're trying to prevent. So that's why look at their feet. Make them look at their feet. Send them to an educator that will teach them how to look at their feet. Get them to quit smoking. Get their blood sugars under as good a control as they can do. Foot deformity, also looking for deformity. So if you've got bunions, if you have these kind of swan toes, hammer toes, they put pressure on odd parts of the foot. This part of your toes were not meant to bear any kind of weight or any kind of pressure, and so they'll ulcerate. When you do that, then you've got undue pressure here, they'll ulcerate. So you see the calluses form or the blisters form. So talking to people and educating them about how to take care of their feet has been shown to decrease amputations and ulcerations by about 25%. So I'm going to show you how to do a foot exam. We'll go over and use a monofilament. You'll use a tuning fork. We'll look at how vascular changes occur. We'll look for the common foot problems. We are not going to do biomechanical foot assessments, but they have these fantastic maps that they can have people walk across, and they can map how their feet are bearing weight, and then they can make adjustments based on that. So orthotists will take those kinds of readings and molds of the feet, and they can shape insoles for the patient's shoes that will then help them bear weight in a normal way. So people who have ulcerations, who have insensate feet, you can refer them to an orthotist, and they will make insoles for feet, for their shoes, that will help them offload and bear weight more normally. So prevention. Prevention is blood sugar control, good foot care. If they do have diabetic neuropathy, very difficult to control pain. The two drugs that are probably most commonly used now are duloxetine and either gabapentin or pregabalin. The tricyclics, the old TCAs, amitriptyline has great data behind it. It's just a hard drug to tolerate. Causes lots of hangover effect, fogginess in the morning. So many people have moved more towards the Cymbalta or the gabapentin. Fairly common. But I'm telling you, it will not control the pain totally. If their sugars are really high, one thing that will happen is that if you get their sugars normalized, the pain will get better. So acute onset of neuropathic pain, if you can get their sugars down, it will improve. Once you've got sustained damage to those nerves though, the pain, you can only temporize them with these agents. Now, the good and the bad news is eventually their nerves will burn out. The pain will go away, but so will all their sensation. Okay. So then they really need good foot care so that if they do have an injury, they seek care in a very timely fashion. Next page. I think I've said most of these. Let me go to page 10. One of the things I'm going to teach you is just the different things that you would teach a patient and that you can do very quickly. When you're doing your foot exam, you can go over and cover these points. These kinds of things will go a long way in helping them protect their feet. So one of the things we teach them every day is before you put on your shoes, run your hand around them and make sure there's nothing sticking out. So if they've got some loss of sensation, they cannot feel a pebble in their shoe. In fact, I've got a little nail. So if a nail comes up, then they won't be able to feel it. It'll just keep burrowing into their foot and they'll never know. Looking for little rocks, anything that's unusual, at least they can get it out. Looking at their feet every day. Every day we want them to look at their feet. I don't care if they're normal. It's habit you want to establish. So you want them to look at their foot every day. Anything that's abnormal, you want them to call you within 24 hours. Any cut, any damage. We'd like them to wear white socks because when they take the white sock off, they can look at it. Is there blood? Is there any discharge? Then they need to call you. Those kinds of things you need to establish. If you see something on your sock or on your shoe, I want to know about it that day. If they are too big to look at their own feet and there's nobody in the house that will do that for them, you can lay a mirror on the floor and hold your foot above it. Okay? So that's the way we work with the really obese. So good shoes. I tell patients if you can only invest in one good thing in your wardrobe, buy a good pair of shoes. We also talk to them about being able to test the temperature of their water. So you can buy these little things for babies, you know, the little temperature things that you can throw in the bath water. I tell the patients do that, buy those and throw them in the water, because they cannot tell you hot water from cold water. So you tell them a temperature, keep it below that temperature. Toenails, keeping their toenails cut straight across if they can still cut them. If not, if they are Medicare, you can refer them to a podiatrist. They can be seen every 4 months. That'll be covered by Medicare. They'll clip their toenails, they'll do the foot exams, and they can go a long way to helping you maintain good feet. Never go barefoot, never. I can't tell you how many patients I have seen who have got, I had one lady who came one day and I said, okay, why are you here? And she said, well, I got this needle stuck in my foot and they found out I had diabetes. So I pulled up the x-ray. She had a needle this long embedded in her foot that she never felt. It just kind of kept bothering her, so she went and saw the x-rayed her foot, and here's a needle. So don't go barefoot. Don't go barefoot. Needles, all kinds of stuff. My sister is a seamstress. I can't tell you how many needles I stepped on in our jag rug because of her dropping them. So never go barefoot. Not outside, not inside. And we usually tell them wear a shoe, a house shoe that has a rim around it. So if you get up in the middle of the night, go to the bathroom, you don't stub your toe, and that can cause damage and takes them a long time to recover. Keeping their skin moisturized. They tend to dry out very easily. You'll see this. You'll pull up their leg, and it's just one big flake from their toes to their knees. If you don't like feet, you probably won't like diabetes. Interesting stuff, though. Man. Okay, let's take a break, and then I'll come back and finish up.